All right, everyone. We're at time, so we're going to get started. My name is Andrew Chou from Brigham and Women's Hospital.
I'm Rebecca Cash from Mass General.
All right, we're here to really talk about the data sources in emergency care research. These are our disclosures. There's none from me. So why is this important? You know, I think most of us started somewhere in academic medicine, and we just started off with no time, no money, no grants, no people to support us, no analysts, no ones to write grants for us. So it's really tough to have a research question in which you have to collect data. You know, you may need to collect hundreds or thousands of subjects to actually answer the question appropriately with good power, and that takes time, that takes money, which you do not have when you start. So that's where existing data comes invaluable. When you have existing data that is relevant to your question, you can leverage that and skip over a lot of time in learning the logistics of getting enrollment, getting complicated IRB reviews, and really allow you to focus the time on your own study, your question, honing that study design to make sure it's valuable and produce a research that is really good instead of trying to encompass the entire study with data collection. And most importantly also, these data sets, most of the time, there's a lot of data sets out there, and a good amount of them are actually either free or come with very little cost. And it's really a perfect setting for somebody who's starting off in academic medicine. I know I started with that as well as many of my colleagues that I know who are really quite far along in their careers now. And you may think data set analysis, it's just secondary analysis. You know, how impactful can it be? There's so many research that's out there in impactful journals like JAMA, Resuscitation, Circulation. The list goes on. So you can certainly make very impactful research off of these data sets. As long as you ask the right question and making sure your study design is robust, you can make as good as a study as any. There's so many data sets out there. Today, we're going to focus on a couple just in emergency medicine. But before we dive into it, it's really important to think about how do you select the data set. And as we go through it, I want you guys to pay attention to a couple of things as we go through. The first most important is really where the data comes from. How did they collect it? Who's providing the data? And what kind of quality of the data it is, meaning that is there enough detail in there to answer your question? Or if there isn't, is it good enough? Or is it just completely unanswerable? And sort of do they have the data that's relevant to your research question as well?
All right, so once you've selected a data set, then you need to start thinking about the logistics of using it. Some of these data sets are available online. You just go online, you download it, and you can go ahead and use it, but most are gonna require some sort of request process. So you have to submit like a project proposal. What's your hypothesis? What's your objective? How are you going to be using these data? And once that gets approved, you have to sign usually a data use agreement. So DUA is a legal document between the person or organization providing the data and you as the researcher or sometimes your institution. The DUA process is very institution specific. So, whatever I say here is superseded by your institution's policies. Oftentimes you have to go through like a research management office to get that signed. Beyond protection of the data, you also need to think about human subjects. So these are secondary data. You're not collecting data from humans. However, a lot of these are limited data sets in that they have some sort of identifiable information. Maybe it's a data service, a date of birth, or like an address where the patient was found or lived. So we still have to submit these sort of projects for IRB review. In most cases, you're not allowed to sort of self-determine that the project is exempt. Most oftenly, with a secondary data set, the IRB will come back and will say that it's an exempt project because of the 2018 common rules where IRBs operate under, but occasionally, it may be considered not human subjects or have to be have an expedited review.
So today we're going to focus on a couple of data sets here. I won't name them since we're going to go through them. So the first one is the Nationwide Emergency Department Sample, or we call it NEDS. It is an extremely large data set collection of hospital-administrated data. This is actually a federally funded project through AHRQ, where they partner with about 42 states, usually for each year, around high 30s to low 40 amount of states will participate. And basically each state authority that collects hospital administrative data will contribute to this data set in HRQ. So each year you can anticipate about like 28 to 30 million visits exist in this NEDS data, which is very, very large. So with it covering such a big portion of the United States kind of emergency departments, it actually is very, very good at providing national estimates as well, and it provides some ways to allow that, even though it's not a complete entire USA data set. The key here, though, is that it's a hospital-administrated data. So it does include some patient demographics, such as the age, if it's male, female. Not until recently, it didn't include race until 2019, more recently. It does provide some visit characteristics, such as is it a weekday visit, weekend visit, but not the day of the visit. But it does provide the month as well. But most importantly, most people use this for the diagnosis. It has an exhaustive list of 35 diagnoses, including both acute and chronic diagnosis that's entered on that administrative record. Because these data are collected from hospitals, it also actually includes a good amount of hospital characteristics, such as is it for-profit, nonprofit, is it rural, urban, is it teaching, non-teaching hospital, and a trauma level designation. This is just a brief graph about sort of most of the states that contribute pretty much geographically quite diverse, with a few exceptions that did not contribute. Most people use this data set to really look at broad trends in emergency care practice. As you imagine, this is a national data set, and it's really easy to see, how has the patients in the emergency department changed? That's one of the papers that's published in JAMA IM that showed that complexity in ED patients have increased in terms of age and number of comorbidities. You can also look at variation in admitting practices. One prominent paper looked at variation by hospital in terms of how frequently they admit by different conditions. And with such a large sample, it's also very useful if you want to look at specific conditions, especially rare ones, where if you're looking at your hospital, you get like 1, maybe 2 cases, but if you're looking at the data, you're going to get a good sample here. It does cost about $1,000 per year. If you're a student, have a valid student ID, it's $250, so keep those student IDs around. But it is a cross-sectional data. You cannot track them across years, and you cannot track patient visits within the same year. It does have it's a huge data. It will require a lot of data analytic resources. And lastly, it just has very limited clinical granularity, meaning that it doesn't have vital signs, it doesn't have the date of the visit, it doesn't have test results, if you will. So it's a very much broad, kind of high-level data set, but with a lot of visits here. But speaking of clinical granularity, this is the second data set we'll go through, NEMSIS. Pretty much everybody has heard of NEMSIS. Very, very popular data set, probably because it's completely free and you can just download it. But it is essentially medical record reviews done by U.S. Census agent through the CDC. And they do a 3-stage probability sample design. And the only thing you need to know from this is they just use the strategy so that they'll sample every single state as well as every single sub-region within each state so that they can get a sample of around 15,000 to 33,000, but able to use that to back calculate an estimate with incredible accuracy, providing national estimates of visits and volumes. The data within it, again, it's very rich, so it's very much everything that you can think of that you can do with an EHR review study. So obviously it has the typical patient and hospital data you would expect, but the visit data is extremely valuable here, especially presenting symptoms. That is not existent in any other data set that I am aware of so far across emergency care data sets. But otherwise, diagnosis, procedures, disposition, that's all in there as well. So a couple of uses of NEMSIS include, again, kind of general trends across the specialty and how the care in the ED has changed. We have looked at diagnostic testing. We have looked at advanced imaging before. Recent paper looking at Foley catheter use over the years across EDs. There's also been papers in JAMA by Dr. Raven that looked at the poor correlation between presenting symptoms and diagnosis, and how insurance companies shouldn't reject certain claims based on diagnosis because you can't really, that's a after the fact judgment. So The limitation of NEMSIS is, again, it's a cross-sectional data set, meaning because it's taking samples each year, so you can't connect visits across the years. And it's also a fairly limited sample size at the end of the day. It is, again, 16 to 30,000 per year. So if you're looking at specific condition, you may end up with like 10, 12 visits per year, and that is really not enough power for any meaningful analysis.
All right, so beyond looking at the emergency department patients, we can also look at the emergency departments themselves. So the National ED Inventory, or NEDS USA, is an annual survey that's conducted by the Emergency Medicine Network at MGH. And it's a really unique survey because it captures all non-federal, non-specialty US EDs. Most data sources about EDs would group satellite campuses in with the parent campus. However, NEDS is unique in that those are included as a separate entity. So there's about 5,500 EDs that are surveyed every year. The data are available from 2001 to 2021 at the moment. The 2022 data are being collected right now as we speak, actually. It requires a proposal to use, and the cost can be dependent on the project that you're working on. So the annual survey collects some basic characteristics only about the ED, so things like visit volume, do they have a PEC in their ED, do they use telehealth? The annual survey is then supplemented with lists of capabilities and specialty certifications for trauma, stroke, PCI, and burn center. And those center data can be requested separately from the survey data. All of those data are then populated into a free smartphone app that's called Find ER Now. There's a picture right there and a QR code if you'd like to download it. And it's a really interesting app where you can open it up anywhere in the US and it will tell you the closest EDs and all of their capabilities. So NEDS is unique in that it's about the EDs. The best thing to use this for is to describe ED characteristics, especially over time. However, there's no patient-level data included. There's no outcomes of a patient. There's no clinical information at all. The other limitation is that it's a survey, and so some of the variables are self-reported, things like the visit volume, and so they're subject to information bias. There's also lots of registries out there. Registries would capture some specific disease process. One that we're going to talk about is specific to cardiac arrest. So the Cardiac Arrest Registry to Enhance Survival, or CARES, is a collaboration between Emory University and the CDC. There's data available for about the past decade and more than 700,000 out-of-hospital cardiac arrests. There's both the national CARES and then there's state-level data sets. The national CARES, the original way they collected data were only for presumed cardiac etiology arrests. But since 2013, they've included all non-traumatic arrests that EMS worked in some way. Using national CARES requires a research proposal and then executing a DUA. The state-level data sets can have sometimes slightly different policies. The cost is dependent on your project's funding. So it's actually free for unfunded projects, but if you have funding, they do charge a small amount. So like I said, there's both state level and then there's also individual EMS agencies and cities that will submit their cardiac arrest data. So that's a map showing the participants. It follows the Epstein style definitions for cardiac arrest reporting. So it includes things like patient demographics, the arrest and resuscitation information, and then some about the hospital, including outcomes. The intended use of CARES was actually for QI. It was for non-research purposes to benchmark performance for individual agencies so they could improve their cardiac arrest care. However, it's been used extensively for research to look at cardiac arrest care and survival. Some of the limitations, though, are that these are abstracted from the EMS and hospital records, so the quality of what's documented is reflected in the data set. There's also limited clinical granularity in this. So, you might know the patient was defibrillated, but not necessarily how many times, for example. And while there are outcomes, the outcomes are mainly limited to things like survival to hospital discharge. There's not longer-term outcomes included. So we can go outside the ED and disease-specific registries and talk about EMS data as well. So the National EMS Information System, or NEMSIS, is a collaboration between the NHTSA Office of EMS and the University of Utah, where their Technical Assistance Center is located. NEMSIS is very unique in that it's both the repository and the database, as well as the data standard. So all of the sort of equivalent of what an EHR would be for EMS follows this NEMSIS data standard. The data set is huge. Each year is about 30 or more million EMS activations for more than 10,000 EMS agencies and almost across the entire US. It requires a project proposal to use NEMSIS, but then they FedEx you a little thumb drive with the data set on it, actually. So NEMSIS is unique in what it captures. So you have patient demographics, you have incident response characteristics, but it also includes the clinical care that was provided and the assessment and vital signs with timestamps. So you can sort of capture the whole clinical event from start to beginning, or start to end. It has some disposition information, but very limited at the ED or hospital level. So as you can imagine, NEMSIS is most useful for describing EMS care and the epidemiology of EMS patient presentations, but there's some limitations. So there's lots of missing data in NEMSIS, unfortunately, and the data are not, they're not abstracted, they're not cleaned. It is the clinical record that's documented by the EMS clinician, and so there can be variable data reporting as well. The ICD-10 fields that they have for things like symptoms and impressions or field diagnoses are not always mapped to a billable code, and so sometimes it can be a little bit challenging to use those. It's also a convenient sample. It has great coverage, but there is potentially a selection bias in who's reporting to NEMSIS. And because of some of the restrictions for the use of the data, you can't track a patient across a time or event. You can't see how many times they called 911, for example. And you also can't get clinical, or you can't get geographic data beyond census division. So there's 2 EPCR vendors that submit to NEMSIS that also have research data sets, ESO and ImageTrend. And these are subsets of the larger NEMSIS data. You might be wondering, why would I use a smaller data set? But both of these have richer information included, including outcomes sometimes, and more geographic data than what's available in the national data set. So for example, the ESO Data Collaborative, about 20% of those records are linked to hospital outcome data. Use of these smaller subset requires project proposals to each of the individual companies, but then the data are provided for free. There is a cost occasionally if you need help with data preparation or analysis. All right, so we just took a whirlwind tour of data sources, both about emergency department patients, emergency departments themselves, registries, and then EMS data. And so this is a little summary of all of these data sets out there. I'll leave this up there while we take some questions. Thank you.
Any questions? Please go ahead.
Okay.
Like 1 in 30 ED visits happen at VAs. Do you know which, if any, of these the VA reports to?
I know that, so VA, unfortunately, I don't think it contributes to NEDS nor NAMCs. I think part of it might be issues with regulation from that standpoint, but NEMSIS intentionally excludes VAs or other basically non-civilian hospitals. Same thing with NEDS, I believe, because VA actually doesn't report to the state authority, so they actually do not have VA hospital data, although VA themselves have, obviously, their entire data warehouse that's available nationally. So that's another potential data set if you work within a VA that's actually very accessible for you.
Do you have any issues with the timeliness of the data? Like, just because these data sets are so large that like it's years before they're able to release the data that's been collected?
Yeah, there's nothing you can do about it.
No. Nothing you can do about it, but is that
Yeah.
problematic, like, for publication? Like,
Yeah.
have you had
So-
feedback, like, on that, or like getting more patients because you used a database that's 3 years old versus using your own hospital database that's really small, but it's a year ago or six months, just the past 6 months of data or past year of
Yeah.
data?
Yeah, I agree. I think that's essentially a trade-off you sort of make, and I think the biggest example here is COVID, right? So COVID happened. None of these data sets are catching up to it. So, everything that's done, actually VA data is probably the most up to date. And so the first studies you see at the hospital or national level came out of VA. And other studies are obviously within, so for example, I think US ACS actually used their own administrative data to perform studies on COVID because obviously it's not in a national data set. And then, 2020 data started coming out late last year for NEDS as well as NEMSIS. And then we're starting to catch up to see, okay, now we have a complete national picture to see what actually happened. And the other thing related to it is that sometimes these data sets stop. So NEMSIS will stop at 2022. So that will be the last year of NEMSIS forever. So no longer, it will be discontinued. So use it now or never use it again. Yeah.
And I will say, that's not actually as much of a problem with the EMS data set. NEMSIS is typically released a few months into the next year. So the 2022 data set is available now. It's like about a month ago it became available.
Some of these EHR systems kind of gobble each other up. You have like Epic is associated with a ton of hospitals at this point. Are there opportunities are there databases that they maintain that can be used from a research perspective across the country?
You mean the EHR companies?
Yeah, Epic obviously is a
Yeah.
company has access to an unbelievable.
Oh, yeah.
Yeah.
So they keep it.
Yeah, so.
Identify aggregate.
Yeah, for example, I don't know if they publicly sell these data as like a data product that you can use for academic purposes, such as, I know insurance companies usually have an arm that's selling claims data available for researchers. I'm not sure if that's the case for Epic. I do know that the group at Yale has collaborated with Epic and used their data nationally. They actually performed a couple of studies using that. So I think it is possible. I'm not aware of something that's like a segment that they're available. You can email them, try to buy their data for however much money.
Probably not to that much of a granular level, but what about the NHTSA stuff, FARS, the crash data stuff? I mean, and is one part of those, because I know there's some databases there that could be helpful for trauma-related type information. And then are any of these databases linked to the other where they can share information across databases?
That would be wonderful if they could do that. Not to an extent where it's probably usable. I know that for like NEDI USA, we have done a lot of work to link that to some of the HCUP data sets. So you can look at more about the ED and the patient level. NEMSIS, certainly ESO and Image Trend have been linking with their like HDE to some of the hospital outcomes, but it's not a formalized process that includes all of them.
I'll add that NEDS specifically built in hospital identifiers from the HA so that you can actually link that to HA hospital survey data if you want to integrate more hospital level variables into the analysis, and that is very much possible there. But
that's the American Hospital Association, not HEART.
Yeah, American Hospital Association. But yeah, otherwise, like, really uncommon that these data sets will be able to talk to each other. When you move into the space where there's commercial claims data, insurance claims, it is possible to actually link to, for example, mortality data when you have individual identifiers. But again, they're not inherently designed to be integrated with each other.
Social Security Death Index, any value to that?
If you can link it into the data source, it would be a very good source of the final outcome. But I don't know of, you can do that for like NHAMCS, that's linked in, but it's not necessarily as relevant to like emergency medicine research questions.
And that's what insurance companies sell. Like they will link their claims to the mortality data and then sell you that for like tens of thousands of dollars per year.
You mean they don't give it away at the kindness of their hearts?
No.
I tried to convince them. They said no. I'll try again next year. All right. Any other questions? All right. Thank you so much.
Thank you.
Appreciate it.